in First Nations and settlers in Australia. I want to acknowledge that despite that colonisation, 60,000 years of wisdom continues, and so too does non-Aboriginal Australia's obligations to take a personal and daily responsibility to support reconciliation through truth and justice. Today I speak with Professor Sharon Friel. Sharon is an ARC Laureate Fellow, Professor of Health Equity and Director of the Menzies Centre for Health Governance at the School of Regulation and Global Governance, RegNet for short. That's at the Australian National University. Her research focuses on the political economy of health, governance and planetary, social and commercial determinants of health and health inequities. Her 2019 book, Climate Change and the People's Health, highlights the importance of addressing global consumptogenic systems. Today, we spoke about some of her recent work with colleagues called Power and People's Health. We often talk about the social determinants of health, what structural or social factors lead to health or ill health. We've been talking about it for decades, that social policy and health policy, as well as health governance, needs to look beyond the health system towards social policies in housing, planning and trade, including policies that are controlled and implemented by local communities. But despite decades of research supporting this, it does not happen. Power. That is something we often talk about when discussing how the social order remains intact to the benefit and disadvantage of different communities and sectors. Reading Power and People's Health and talking with Sharon today, I saw for the first time a framework that can help us examine in empirical terms how power sustains racism, sexism, and neoliberal ideologies that continue to undermine health and the health system. I hope you enjoyed the episode. So please subscribe, rate the podcast. We're available on Google Podcasts, iTunes, or anywhere else you can find your reputable regulation podcasts. Well, thank you so much for coming today, Sharon. As you know, the first question on this podcast is, why does regulation, you'd think I'd get that right if I ask it so often, why does regulation matter to you and to your community?
Thanks, Simon. And so first of all, just to acknowledge that I'm joining people from the lands of the Ngunnawal people. I'm here in Canberra, and to pay my respects to elders past and present and emerging. So what's regulation? Well, so I'm in the School of Regulation and Global Governance here at the Australian National University. And we really think about regulation and governance in a very broad sense, a very holistic sense, really around influencing the course of events. So it's that broad, which of course means everybody, everything influencing the nature of society and the way we live our lives.
It's pretty broad, isn't it? And I think that's really interesting. I think that's when you highlight that, hopefully you're highlighting the value or the significance of the podcast, in the sense that most people think of regulation, including a lot of practitioners, in quite a narrow sense of delegated legislation, often from law, like regulations themselves, or just a very strict kind of legal approach. But it sounds like you're taking a broader interpretation, which I might share.
Yeah, absolutely. I mean, if you just think of, we sort of talk about it here in the building of, you walk into our building and the first thing that you see are stairs. So there's sort of architecture, interior design has regulated our behaviour. Yeah. It draws us to use the stairs rather than the first thing we see being the lift. And I just think it's such a lovely, simple reminder of regulation happening on a daily basis in a way that can be organised through interior design, or it can be through legislation, or it can be in the sort of the private sphere as well. And yeah, I mean, we're going to pick up on all of that, I'm sure. But yeah, so it really is that broad, I think.
Yeah, absolutely. And when you give that example, I think of green lights, red lights, structure when we go, and then that sits within a legal kind of framework as well. And I do a lot of my work in mental health, and regulation in the way that you're talking about it can be for better or worse. And a lot of people have their movements regulated by being detained in a psychiatric facility, and the design of those facilities regulate how people behave. So often they'll put the quote unquote nurses station in the middle of the inpatient unit. And so that's so that people can, have visibility of all the other patients in that area. And so there's kind of a surveillance kind of function to that too. And so, yeah, I suppose I'm just...
Yeah, exactly. Yeah.
And I mean, when you, that example probably moves quite well into the next question I had, which is that a lot of the work that you're focusing on is, well, I won't say a lot because I've actually looked at the things you've written, and you've written about 4.5 million papers. But one small pocket of about 100 papers you've written focuses on the interaction between politics or power and health equity. Firstly, could you explain what you mean by health equity? That won't be obvious to some people. And then the relationship with politics or power.
Yeah, so health equity, and well, maybe I'll start with health inequities, really speaks to this idea of the differences in health outcomes for different populations, different nations, being not just unnecessary and avoidable, those differences in the health outcomes, but also incredibly unfair and unjust. So inequity and equity is just really the opposite of that. And it's the absence of health equity, is the absence of these. And so it's a very deliberate term. In some countries, you speak about health inequalities. In some countries, you speak about health disparities. But health inequities is getting to the avoidable and the injustice in the fact that they exist and they're not being avoided. And so your question of this sort of being intertwined with politics and policy and power. So thinking about, so what drives health inequities within societies, between societies? And because we see these systematic patternings, it's not a chance thing. It's very deliberate. Well, yeah, sometimes it is very deliberate, but it's socially influenced. Yeah, and you're going back to your regulation, steering the course of events or influencing the course of events. And so the choices that are made by politicians, by the bureaucracy, by the private sector, by civil society, by us as individuals. All of that, politics, policy, power, shapes the daily living conditions for people. And those daily living conditions are very unequally distributed. If you think about your quality of housing, access to housing, quality of housing, education, our employment conditions, you're very socially graded, and that gets into our minds and it gets under our skin, and that affects our physical and our mental well-being. So as soon as we take a social model of health and we understand that there is something about society that is shaping health and the distribution of health outcomes, that immediately takes us into questions of whose interests are best served through policy, through political decisions. And then that starts to ask the question of, well, if certain interests are served better or worse, who's got the power in those systems that is shaping our daily living conditions. So it then starts to get really mixed. Health equity you ask me about health equity, and we have to talk about politics and policy.
Yeah, absolutely. And I just reflect on when you talk about, when I don't want to say we, because I'm not nearly as expert on these topics as you, but when people who work in policy talk to lots of people out in the community, they'll often attribute these differential health outcomes to quote unquote education, or a lack of education on behalf of certain communities. And I imagine, I mean, even the fact that that people come to that view, I think is a political or an expression of power in some ways, that they come to view or potentially indirectly blame the marginalized communities. But I guess, how do you respond to that? That maybe these things are kind of just a result of a lack of education or good health behaviours, perhaps on the behalf of those communities. That's not my view. That's obviously just a view that's put forward. Yeah.
Yeah. So I think there's a couple of things in there. One is, we live in a society, the past few decades, it's been very much of an individualized society, individual responsibility, a small state, greater personal responsibility. And so that discourse, that paradigm enables that sort of response that you're speaking about. But there's also, I think, the differentiation between sort of equity of opportunity and equity of outcome. And so when somebody says, oh, but look, there's education available to everybody, or there's housing available to everybody, we've got plenty of housing. Well, actually, and so that the argument going equity of opportunity there. But of course, that absolutely does not recognise the inequities in the resources that different groups in society have access to, that have been, like you speak about, marginalised societies, which of course undermines people's social capital, cultural capital, a whole range of sort of capabilities. So we don't actually have equity of opportunity. There's a load of stuff out there that's available, but not every group in society is equally resourced to make use of them. When we start from a question of equity or inequity in the outcome, which I would love us to do, then we see that, well, actually these opportunities are not equally distributed at all, and addressing those systematic structural inequities is vital to get to the equity of outcome. So the discourse or the response that you rightfully highlighted, which is by far the most, a very common response, not the most, but a very common response is, sort of mixed up in those two things that I've been speaking about.
Yeah, absolutely. And I mean, when you talk about those two, equality of opportunity and outcome, there's kind of a minimalist and maximalist approach in my own mind to justice or health justice. And you talk about the different resources to even access those opportunities in terms of equal opportunity. I just, imagined that there is housing, but to use your metaphor earlier, there's no stairs to get there, for that, or that community doesn't have the money to build the stairs to get there, or, they're on worse ground, so you can't build stairs on that ground, or so, I'm probably taking the metaphor as far as it can go. So you and some colleagues on this topic, you wrote a paper last year, which is the reason I reached out to you. It was called it's called Power and People's Health. It examined how power shapes public policy for health equity, the two kind of key concepts that we spoke about just now. You've been in the academic game in a while, so I imagine you've had these conversations, or you've been looking at these issues for a long time. what motivated you to really, and it was a huge paper that you wrote. What motivated you to investigate the two concepts here of, power, health equity, and public policy? All three.
Yeah. So much of my research historically, and in the field of the health equity, social determinants health equity field, a lot of our attention historically had been kind of shining the light of the existence of health inequities, showing the extent of health inequities within and between societies. And that was very important, shining that light. And then there was work, and I was involved with the World Health Organization's Global Commission on the Social Determinants of Health and Health Equity. And we reported back in 2008. And that was a huge global endeavor that pulled together all of the evidence, a lot of the evidence from around the world, showing some of the actions, policy and otherwise, that could be taken across a range of domains. So types of action that was needed to do with employment conditions, the types of action that might be needed in urban planning, the types of conditions or the actions that might be necessary within, to do with globalization. And so we identified the types of action that could make a difference to health inequities. And yet nothing happens. Now, I'm not so naive to think that evidence has a linear relationship to action. Of course it doesn't. And I'm certainly not naive to think that our report makes much difference in that, getting action to happen. But where this research that you were speaking about, the power-related research, was, we were sort of starting to say, myself and colleagues, there were a number of colleagues involved in this. This was a big 5-year NHMRC grant that came out of that grant. And we were asking the questions of, well, if there is a lot known about the types of effective remedial action that could be taken to address health inequities, why is it not happening? Mm-hmm. And so if the political science literature tells us, power really matters in policy processes, it shapes what gets onto a political and a policy agenda, what interests get advanced, who wins, who loses, and all of that. Power within the policy processes influencing the implementation of policy as well. Even if you get a bit of advancement of a policy agenda that addresses these sorts of issues, when you get to the implementation stage, sometimes it slips, and we see it slips to that individualized responsibility again. So we just kind of wanted to know, was power in the policy system an important factor in preventing action happening in a way that, we've got all of this evidence, why is it not happening?
Yeah, and I can't stress enough for the listeners to go ahead and read this article, because I think it is I think you've just started something in terms of providing a framework that we can assess lots of different policy domains with. You touch on quite a few different policy domains around closing the gap, around the things that policy frameworks or decisions that impacted health outcomes, if I remember correctly. So closing the gap, the Trans-Pacific Partnership, and I think you identified, from my recollection anyway, that there was a tendency for power to frame even how the issue was understood. So you talked a bit about, and I see this in mental health, biomedical kind of framings of the issue can lead to certain, I guess, solutions proposed, but then also to what you're talking about, how those things are implemented as well. I imagine that was a pretty strong finding out of the research.
Yes. So just for the listeners, if you're interested in sort of looking at it, so we interviewed 158 kind of policy actors, so ex-politicians, the bureaucrats, people in the business world, and civil society actors across a number of policy domains, and you were mentioning some of them there. So we had 7 policy case studies. So, and these were all areas that are the social determinants of health inequities. So trade policy, the Trans-Pacific Partnership Agreement, we looked at the NBN, so in terms of digital equity issues, paid parental leave, a very important social policy, the Northern Territory emergency response as well, back in 2007. We looked at the Western Sydney City deal, so an infrastructure policy, closing the gap and primary healthcare. So a whole suite of domains, and people listening might be saying, what on earth do they have to do with people with health equity? Well, these all shape our everyday living conditions.
Absolutely.
And then that matters for obviously for health. And so trying to tease apart what was happening across these 7 cases. Who were the actors? What were their interests? How were they advancing their interests? So was it an economic interest? Was it a medical interest? Was it a social interest? What were the frames, the discourses that they were using, both publicly and privately, to advance those interests? And what were the institutional processes? Just things like intergovernmental committees, for example, or outside of the government process. So we were examining all of these interests, ideas, and institutions, looking at the different forms of power. So everybody has power. Every actor in the policy system has power, and they've got different types of power. And what we developed through this power analysis allowed us to tease all of that apart. And just the sort of a dominant structural overlay in all of this was biomedicalism, neoliberalism. We live in a neoliberal world. Racism, sexism were all pervasive. So structural paradigms that basically were shaping the rules of the game.
Yeah, the rules of the game. And we had a whole conversation with Professor Fiona Haynes on the rules of the game. And she talks about fields of struggle, and I see there's a lot of overlap between what you're talking about here and her work. And so that framework you're talking about, is that I forewarned, I think, before this episode that I go off track sometimes. So is that the health equity power framework that you're talking about there? And so there's multiple different, for the listeners, there's multiple different levels of analysis that you go through in that framework.
And this is hopefully, we used it from a health equity perspective, but really I hope for listeners, you'll hear that this might be useful in a whole variety of domains. So we looked at the different types of power that are in the policy system. So that might be structural power, it might be economic power, it might be discursive power. I was talking about the way things are framed, might be using your moral power, your sort of moral authority, your expert power, and your network power. So different types of power. And I should say this was all drawing on a number of different power theories exist. But we were also looking at different forms of power. So sometimes it's very visible. You see power playing out in a visible way. So your politician stands up and speaks in a particular way. They're using a particular discursive power in the public arena, so that's very visible. But often it's hidden, it's behind closed doors, and that, of course, is where you start to get very worried. What are the deals that are getting done through that hidden power? The other one, which is even more concerning, is the invisible power.
Yeah.
forms of power. And that's where you don't even know that what you're thinking, your behavior as someone in the bureaucracy, you just kind of, and we saw this in our analysis, that you just kind of automatically move towards an economic goal. And you may not be getting told that, but it's just this invisible power of this dominant neoliberal paradigm at play. And so it's influencing in a very deep way. The other part of the health equity power framework was the spaces of power. So, in a closed space, and that's a very, you just don't know who's in there in making those decisions. It could be invited. So if you think about government policy, stakeholder consultations, that's invited spaces of power. You're asked to put into that. And then the other area that we identified were claimed spaces of power. And this is particularly, you see this with civil society. They might not be getting into the government decision-making table at a point in time. And so they create a whole other arena where the issues are getting spoken about. It might be making use of the media, claiming a space there. And when you start to, and then it all happens at different levels, global, national, and a bit more local. And so when you start to, what we were doing was looking at how these different types and forms and spaces and levels were all interacting through these 7 policy cases that I was talking about. And you think, oh my goodness. Yeah.
It's such a cool, I'm going to stop saying people should read it, but it's such a cool framework. And I do think it should be used in so many different contexts. And I totally resonate with your concern about invisible power and how it can kind of shape. I'm sure there's like a Foucauldian, internalization of, the governmentality kind of theories about internalizing power. I reflect that I used to work in a couple of regulators, and I worked in one regulator in particular, and I went in with really sort of clear picture on what was required, to uphold the sort of legislative standards and the rights of people in particular contexts. And I remember I was just having so many battles to try to maintain this. And I remember starting to think, okay, well, I need to pick my battles a bit more. I'm losing social or political capital here. And I did that more and more. And then I finished that secondment, and I went back to my old workplace, which is, far more bolshy kind of human rights kind of abiding place. And everyone commented how conservative I'd slipped. So it's just fascinating to see how my sort of center of gravity just shifted within an institutional environment. And I would consider myself to be someone who's pretty black and white on things. And so I can totally see, and you see that when you interact with people in government, and I'm sure it was what you saw here, that institutional norms that are so normal that they're not visible they're part of the language, they're part of the furniture, they're part of what holds the walls up, I imagine.
Yeah, exactly. And I think it's that understanding, again, so we're not passive, and we'll sort of come to the hopeful bit in a second, because there were moments of hope. So there's those kind of structures, both visible and invisible, shaping the actors in that system, shaping their norms and behaviors, which of course ultimately affect what policy or practice looks like. But of course, the flip side of that, and this is this kind of dynamic and continuum between structure and agency, is the agency, the agentic side of things, where the policy actors, at the same time, having the potential to recalibrate those norms and the paradigms in which they're, but that's incredibly difficult, of course. But that's the hope. We'll come to the hope. But Yeah, I mean, just some of the, it was just very disturbing to see. And, so in the interviews, I was saying, we did all of these interviews with people, and just the, just horrifying still to hear about some of the incredibly sexist ways of operating. So I'm just going to read you a little quote. So this was to do with paid parental leave, the paid parental leave scheme, and so a quote from industry said. So there was the discussion about who has the responsibility for paying for the paid parental leave. Should that be government? Should it be industry? And so industry was saying, so it would be a very bad thing for women and for businesses, for employers to be forced to pay, because it would most likely lead to discrimination. And so there's a very kind of, I would say a very passive aggressive expression of a very, very sexist approach to thinking about social protection within the country. So I could give you. I don't know if you want for
no. Let's tease this out, because I think that's so fascinating. Did you read that as being an intention? Yeah, like quite an intentional framing of that, or do you think that was an unconscious or invisible one? That reads to me as like a certain level of sophistication in that framing, but I'm not sure, like as in not a good sophistication, but semi-malevolent.
well that it comes back to that thing of the invisible power of these structures, so the structure of neoliberalism, you're just being embedded in industry's way of thinking. Just with, and so it becomes, like you say, the norm. It's just the norm. It's just norm. So I would be very worried if that was somebody sitting in industry just sort of saying, okay, well, I'm deliberately going to speak about it in this way. But of course, that is what that's what the whole PR machine is for as well, isn't it? And government relations people. But or you could say, yep, they sat and they very deliberately crafted that answer. Or you could say there was nothing unusual for that person to say that, because it is completely sensible within that structure of neoliberalism and sexism.
Yeah, the banality of evil. To use that Hannah Arendt's old term. And so, I mean, did you have more quotes? Did you have more things that were revealing in terms of the findings, or more themes that kind of arose out of that? And I'd be really keen to hear any quotes or reflections you have on some of the key findings.
Yeah, well, maybe I've got 3 quotes I pulled out for today, because it really speaks to the structures of racism and colonization. What was dominant. So remember, we were looking at the Northern Territory emergency response thing, and also closing the gap. But so this is all to do with the Northern Territory emergency response. So this was government army intervention up in the Northern Territories. So let me just read you 3 quotes, and it sort of shows 3 different types of power. And so by using the Health Equity Power Framework, plug for the framework, it allowed us to get at these different forms of power. So first quote from a politician. So from the most current government, I think they give lip service to Aboriginal control, and they take a very top-down punitive approach. So that is ideology. That's what I see as ideology, a particular structural intervention among Aboriginal communities. We also saw very sort of closed institutional power at play. So a quote from Aboriginal civil society. I mean, we couldn't even get a meeting with the ministers. You couldn't get to speak to anybody, not even the bureaucracy. There was clearly this plan that had been developed. It was in place, and they were going ahead full steam. Any voice or capacity for us as Aboriginal people to have any say on any of this stuff was completely not even on the radar. So a very closed policy system that with all of these institutional processes that were exclusionary for Aboriginal people.
Yeah.
And then the third type of power, which was the ideational discursive power, the framing, was in, and so this was from an academic, still to do with the Northern Territory, Indigenous people who were represented even in parliamentary debates as being savage and primitive. Mm. So when you think about these three forms of power, the ideology, the structural power, the closed institutional processes that were not allowing Aboriginal voices to be heard, and then talking about Aboriginal people in particular ways, was really just sort of setting the course for allowing a policy like the Northern Territory emergency response to move through.
Yeah, absolutely. And I mean, yeah, it's no wonder that all of those things are revealed in such an egregious policy and a racist policy. And yeah, it's interesting when you talk about, I believe it was, and correct me if this is ideological or ideational or discursive, but something else I see a lot talking with folks who folks from First Nations communities is that often government frames what they're doing as being co-design, as being community-led, and so they sort of are granted. They're able to maintain a closed institutional approach to speak to that second level, but give the appearance or hiding their own power in some of those other settings. I don't know if how is there, question without notice as usual. Is there a way to that the framework makes sense that, or even just off the top of your head?
Yeah, well, and so we saw that with the closing the gap analysis a little bit. So on one hand, that sort of approach gives legitimacy to the policy approach, but in terms of the co-design, co-led.
Yeah.
But what we also saw, which was the small wins that for Indigenous people with closing the gap, was the way that they got to the table, they got to the policy table, was, first of all, there was a claiming of space. There were all of these other venues that Aboriginal NGOs, elders were being very vocal, were saying this is what it could or should look like. Which, I mean, I think that's what we're seeing with the Uluru statement from the Heart as well. That's a real claiming of space, which is opening up some government institutional processes, and that happened with closing the gap. Yeah. So, which then did lead to some co-design around Aboriginal controlled community health organisations. That was a marvelous development. So, and of course they don't all happen in a linear fashion as well. That was the other thing that we saw. So sometimes, it has been kind of co-opted, as it were, by legitimising that, from within the bureaucracy, legitimising a policy approach, but at the same time it does open up some spaces as well to get to the decision-making tables, I suppose.
Yeah, absolutely, and certainly in the mental health space, I've got my own lived experience, but I'm fortunate not to have had involuntary detention or treatment. But a lot of the folks, a lot of my friends that I work with have, and there's often finding a way to get to the table, and other times just building your own table, saying and making it so big and saying, well, you got to come here now. Government, you need to come to us, which I imagine is similar to community-controlled organisations or First Nations communities. Just almost, this sounds like this is such a white way of saying it, but like a proof of concept of we can do this now. Just give us the money to do it, to control it in house.
And it also, of that, it's an empowerment model, isn't it? It's that's bottom up, it's organizing, it's coalition building, it's creating legitimacy, authority, and then it just sort of takes on a critical mass which flips the power in the system, in a sense. So and when, which we also saw, was making use of cleavages within government, or within where the where those interests were not best aligned for health equity. There are often cleavages, and making, so when you've got this kind of growing momentum building in that sort of bottom up way, making use of cleavages within this previously all powerful system, that can flip it as well.
Yeah, and I feel like, again, just to return to your Uluru example, that's a really good example of claiming some space, trying to get into institution. And certainly, 4 years ago, or no, 3 years ago, when Turnbull, made up his third chamber shtick about Uluru, they've been, I know that community has been trying to find those cleavages or ways in, and it's a gradual kind of process. And like you say, sometimes you hit a critical mass and it just flips. And people might only see the surface of that, that flipping, but, there's all of that work that's been done previously. Yeah.
I mean, I don't think we ever see any progressive action without incredible long political struggle.
And sorry, you go.
No, over to you.
And so what are your findings? Is there anything more about what that tells us about our ability to influence public policy towards health equity? So if you're someone listening now and you have a stake in health equity, or you're just realizing that now, are there lessons for you or for them from you about, and your research about, how to influence that public policy approach?
Yeah, and absolutely, because we did see some positive things happening. So, and this, we kind of wrote about this as sort of the weapons of the structurally weak. So I suppose, so the first thing is there are incredible power inequities in the policy systems, incredible power inequities, and there's a real coalition between sort of powerful public and private sector actors, often in very kind of hidden ways, around those economic goals. But there were two big goals for change, if you want to favour health equity, or I would say favour the public interests, in a much broader sense. One is the need to unsettle that coalition, and the second is, which we've seen with COVID, sometimes for good and sometimes for bad, but is the latent power of the state. And the state has the power to advance health equity, but it doesn't.
Yeah.
So what we saw then in the glimmers of hope were, so how do you do these two things? How do you break those coalitions, and how do you activate the power of the state in the public interests? So 4 things: remembering that every actor in the policy system has power. 4 things. One is change the narrative. And we saw that happen. So using persuasive framing, it's not just saying it differently, it's using persuasive framing can really, so you spoke about like human rights, children, future generations are quite powerful narratives. And so using that to kind of break the dominant discourse, so change the framing, change the narrative. Using those claimed spaces to build coalitions. So we saw that in the paid parental leave case, for example, where trade unions, where the sort of the women's movement really, they became the and they were getting to the table. So the health people weren't getting to the table, and they didn't have to be at the table. But these institutional spaces were opening up for these other actors, and if their agendas were advanced, that would be fantastic for health equity. So those coalitions were really important. The second is getting it inside closed spaces. And that's where the sort of the claiming space to create a wedge becomes really important. And I spoke about the example with the closing the gap strategy, like by having that sort of separate claim space, got them to the government policy table, allowing them to help formulate for Aboriginal people to help formulate what that strategy was going to look like. And then the third strategy is making the hidden processes much more visible. For public, really for public scrutiny. It's just shameful, all those hidden agendas and deals that are sort of behind those closed doors. And again, we were seeing that in a few of the cases. Once you made the agendas very visible, publicly known, and I do think at the moment, with the situation with the pandemic, we're now more familiar, more exposed to all of those social inequalities related to health inequities, but all those social inequalities. We're quite disgusted by the fact that like the wealthy have made even more money in all of this. So there's those hidden processes are a little bit more visible and could be a little bit more visible. So these are kind of four strategies that we saw that these structurally weak actors were using. They were using discourse, they were using other institutional processes and coalitions very effectively.
Yeah, absolutely. And I think that's, we've dug deep into the bad, but we've started to dig our way out into finding some hope and some glimmers of hope. And I think that's provides a really effective framework for how to do that. Or I'm sure a lot of these communities have already been doing that, and it'll just be interesting to apply what your lessons are to look at the queer movement and how they've used those, the queer communities use those kind of strategies to change the narrative around a whole range of things. First Nations communities, you're absolutely right. And, the Me Too example. Me Too is a classic example of changing the narrative away from victim blaming, also just changing the narrative's focus away from victim survivor blaming, changing the narrative away from just focusing on the victim survivor to starting to actually focus on the perpetrators as well. And so that is also, we often focus on my observation with a lot of these health inequality debates is we do, and I think this is why I connected with the research so much, is we often focus on who is harmed or the inequalities, but not who benefits from those inequalities. And that kind of speaks to the power that you talk about. And one of the things I'm working on at the moment, which your work is influencing, is mental health stigma. So we talk a lot about how mental health stigma harms people and whatnot, and we've tried so many education strategies and it still continues somehow. And I think it's because we haven't examined who benefits from mental health stigma. Who are the beneficiaries of a society that has stigmatizing attitudes towards people with mental health issues, and who's benefiting from that? And once we do reveal that, then I think that we'll be able to reveal the power, the processes, the mechanisms, and do something about it. And I think it sort of looks back to what you had said right at the start of our discussion, around the sort of the individualizing, we're talking about sort of equity of opportunity, but also the sort of that individual way of thinking. And, it's part of a kind of a biomedical model. Usually.
And it's also this kind of like, we've got to do something to fix people. And I think what our discussion over the past wee while has really revealed is it's fixing the system. It's fixing those structures that create all of these problems for people. But like, it's over here that is. But this, of course, over here is much more politically difficult. And like you say, there's a lot of people in a lot of industries, and I mean that in a very broad sense, who benefit from keeping it on the individual. That's where they make the money.
And keeping it white, keeping it male-centered, keeping it heteronormative. I mean, you talked about the interaction there between structure and agency. And part of it is also taking that, if you're part of those structures, and I am as a white male, as a heterosexual white male, reflecting on how you benefit from that and taking a daily kind of personal responsibility about how you interact with those systems. Because I do think that the only way those systems change, if you're part of them, is you take a personal responsibility to, if you're the beneficiary. I don't mean for the folk who are marginalized by those systems, but if you're a beneficiary of those systems, I just think it's incumbent upon you to take that personal responsibility. Otherwise, because I hear a lot in policy at the moment, the system's broken, and I don't like that narrative. I think the system's doing exactly what it's meant to do. We hear that a lot in the mental health system. System's broken. Maybe, sure, there's underfunding and whatnot. I'm sure lots of the other health systems you work in are broken, or maybe it's just working to the agenda of neoliberalism. To follow your logic, and the system needs breaking. I don't know. If that.
Yeah, I think that's a lovely way of saying it. The system is behaving in the way that you would absolutely expect it to behave, given the paradigm that it's set up to both advance and is being structured by. I love the idea of breaking the system. That's awesome.
Oh, well, it's not mine. I'll find the quote and put it in the show notes. So, okay, let's do some system breaking. So, what can we ask our politicians to do to improve health equity then?
Yeah. I suppose I've been sort of reflecting, we've got a federal election this year, and it just seems to me that there's this ongoing sort of ideological context between sort of a social justice agenda versus an efficiency agenda.
Inspiring, right? The latter, yeah.
I haven't got an answer for how you make it. It's just that's down the sort of the party lines. But I do know that all of the evidence tells us it doesn't have to be an either or. Certainly, when you're thinking about health equity, it doesn't need to be an either or. An efficient system, it can also be an incredibly equitable system. And so, I would love our politicians to understand that and then put in place, or to kind of mandate, to understand then that public policy creates and distributes resources that matter for health equity. Because the politicians that I speak to who are not health politicians don't understand that what they do in their portfolios really makes a difference to health equity. The idea, conversations that I've had in the past with trade ministers, and they just think I've come from Mars, why am I sitting across the table from them? Yeah. So please understand that the broad sweep of public policy affects health equity. Then, but you're going back to this idea that the state has all of the powers that it could, that is needed to improve health equity. If put in place, if we broke the system as it currently is, and put them in place, they're there. So kind of use them, please. And we've seen some of that with the pandemic. The other thing that we know that really matters in terms of political will and generating movement is for politicians to be vocal in their support for social and health equity. Like, they've got to stand up and be courageous and say these things matter.
Yeah.
Then they've got to empower the bureaucracy. So it's one hand having a politician stand up and saying all of that, and of course the bureaucracy isn't empowered. I mean, I despair that so many parts of the bureaucracy are just not empowered to advance these sorts of agendas. So, like, empower the bureaucracy to put these sorts of actions in place, that everything is focused on equity implications.
Yeah.
And then the final point is politicians make sure that we've got inclusive governance processes, which of course we absolutely do not, and that we need much greater diversity, and that all the old white men get away from the table.
Well, we found our grab for the 5-second promo grab. I love that. No, those are a wonderful set of we'll try to visualize that, because I think they're a wonderful set of criteria for how we can improve our system. I do think that just on the point of empowering the public sector, you can just see it's been death by 1,000 cuts over 15 years or so. And in one of the earlier episodes, I spoke to Professor Terry Carney, who does some stuff in social security law, and we spoke about robo-debt, and that there's a whole bunch of reasons why robo-debt happened the way it happened, but including regulatory failures from the oversight agencies. But the cutting back of the APS, the Australian Public Service or sector, and the de-skilling of that space just meant that they never identified any of these issues. And I mean, I imagine this is just front and center. That could have been the eighth case study, really, in terms of just the horrendous mental health outcomes from that policy that we hopefully are going to examine through a Royal Commission. So I think you've made a compelling case of how what health equity is. How we should understand it as equity of opportunity or equity of outcome. I hope my comrades on here are outcome focused. The interaction between that and power, and our power often influences public policy at multiple different levels in lots of visible or invisible ways to kind of reinforce the status quo and maintain those inequities. And that's why we continue to see them. But coming out of that sea of despair, we see some hope in the ways that other communities have claimed that space, changed the narrative, and forced government to come to them in a way. So I think you've given us that redemptive narrative. But what's one thing that you want the listeners, to go away and do after hearing you today?
Yeah, so use your power. Everybody has it. It exists in multiple forms. You might not feel structurally powerful, but you've got discursive power, you've got institutional power. It plays out in many different rooms, so have an explicit focus on power, on your power, on institutions and where you work or study or hang out. Use it to get action on social and health equities.
Fantastic. Thank you so much, Sharon. It's been my pleasure.
Lovely. Thank you.